Good morning. Today we're going to talk about acid-base balance and how it affects the body. We're going to go over some conditions that cause disorders in the acid-base balance process, and we're also going to go over different ways to treat acid-base balance disorders. So the body utilizes acid-base balance in order to maintain homeostasis. Homeostasis is a state in which everything in the body is functioning properly and there's no mishaps in that. The definition of homeostasis is any self-regulating process by which biological systems tend to maintain stability while adjusting to conditions that are optimal for survival. In essence, it just means everything is all good. So to break that down is that when some outside force affects the way our body functions, our body naturally adjusts to maintain homeostasis. And homeostasis is a constant state of well-being. And we can compare how our body maintains homeostasis to the way we compare how we maintain a swimming pool. So when we go swimming in the summertime, we want to ensure that the pool is at its peak optimal condition so we can enjoy it as much as possible. If something is off in the swimming pool, then we could result in chlorine burns or rashes or skin irritation, and we just won't enjoy the pool as much as we would if it was in peak functioning condition. And that's what we want our body to do also. We want our body to be in optimal performing condition so that way we don't suffer any kind of negative consequences because of that. So when we manage the pool correctly and the chemicals are balanced, the pool can be utilized to its expectations, meaning we can enjoy the pool without any kind of negative consequence. Same is true with our bodies. When we have the correct chemical balance in order, we can perform and survive a lot easier than we could if something was off. When our chemicals are in balance, homeostasis is in place, everything is all good. So just like a pool has multiple facets to maintain balance, our bodies have similar systems in place to ensure homeostasis is made, which means that our bodies utilize many different concepts and many different functions to keep us alive and keep us performing to our best. And our body changes and adapts even if there's external or internal factors fighting against us. Something like physical trauma or illness or hot and cold. Our bodies adapt and try to change to maintain homeostasis no matter what the environment is or what we're being faced against. So if something in the pool fails, the chemistry of the pool becomes altered and somewhat unstable. It's unable to function, and we're not able to enjoy the pool like we would as if it was in peak optimal condition. If these symptoms aren't fixed and we don't take care of the pool the way we're supposed to, whether it's by adding chemicals or taking away chemicals or making sure filtration is the way it should be, the pool becomes inhabitable and the pool, quote unquote, dies. So nobody wants to swim in a swimming pool that looks like that with green algae floating all over the place, and that's just not prime condition for the swimming pool. And the same is true with our bodies. So if something fails or a system is not functioning up to its proper performance, homeostasis fails. We're unable to be in the all good scenario, and our bodies have to work harder to try to fix things, but sometimes, unfortunately, it becomes too late and our bodies can't adjust or fix what needs to be fixed, and it's up to us to try to, one, recognize what's going on, and two, fix what we can fix. So if the chemistry in our body becomes altered and our body's compensation isn't able to keep up with that, then we end up like this patient right here and we die. So everything is not all good if our body's chemistry systems get altered. So the body has three main processes or buffer systems to maintain homeostasis and proper acid-base balance. The bicarbonate buffer system, the respiratory buffer system, and the renal buffer system. They all kind of work together in order to maintain proper acid-base balance so our body chemistry stays in check and maintains to operate at our peak performance. And we can use pools to kind of correlate between that. So the bicarbonate buffer system kind of relates to the chemicals that we put in the pool, or how we add chlorine or bicarbonate to the pool to make sure that the chemical balance is optimal for use. And then the respiratory buffer system kind of relates to the leaf traps and the filtering system that's in the pool. So everybody who swims in the pool, we know we have the little traps on the side, and they catch debris, and when the flap does like this, it pushes the clean water back into the pool. And then the renal buffer system kind of relates to the pump on the pool. It filters out unnecessary waste. There's multiple filtering processes in it, and then it releases clean filtered water with the correct chemical balance back into the pool, sort of like how our kidneys relate to our bodies, filtering waste and turning it into urine. So a little bit about the bicarbonate buffer system. When the pH of a pool becomes too acidic, we add a base to the pool, and that base is actually sodium bicarbonate, and that neutralizes the acid. It's the same thing as baking soda. You just add a whole lot more to it. So it's a natural occurring chemical, and that's what our bodies do also. So when the pH of our body becomes too acidic, sodium bicarbonate is used to convert a strong acid such as hydrochloric acid or hydrogen into a weaker one, which is then passed through the body and exhaled through the lungs. It doesn't significantly change the pH of the body, although it's a continuous process, sort of how the chemicals in the pool are a continual process of maintaining proper pH of the pool. The respiratory buffer system, that's related to the leaf traps of the pool. As you can see right there, it's taking in the leaves, but it's also pushing clean water back into the pool. We exhale carbon dioxide, which is acidic in nature, in order to maintain proper pH of the body. But at the same time, when the respiratory system becomes clogged, just like when the leaf trap becomes clogged, we can't release that acid, that carbon dioxide appropriately, and our pH of our bodies becomes in an acidic state, or acidosis. So we need a properly functioning respiratory system or leaf trap in order to maintain homeostasis, so we can exhale all of that acid into the air. And then the one that correlates the best is the renal buffer system and the pump of the pool. So the renal buffer system filter waste, just like a pool pump filters waste and filters unnecessary products to prevent it from backflowing into the pool. So the renal buffer system does the same thing, and the end result is that it excretes it from the body in the form of urine, and urine is acidic. So now that we kind of made a vague comparison of how a pool relates to our body, we can talk a little bit more about pH. So the pH scale is a numeric scale that runs from 1 to 14, or 0 to 14, depending on which scale you're looking at. 1 is the most acidic substance there is, whereas 14 is the most alkaline substance or basic substance. And it kind of progresses towards neutrality, which is 7. 7.0 is completely neutral, meaning that it's not acidic and it's not basic. So if we look at our chart right here, we have the arrow pointed to green, and that's where equilibrium in most states take place. Drinking water is a 7, or not drinking water, but distilled water is 7.0. So if we look at what we're drinking, if we drink water, it's neither acidic nor basic, which also is good for our bodies. So something to compare a pH of 1 would be like stomach acid or hydrochloric acid. battery acid, which we see in car batteries or lawnmower batteries, is actually considered a 0. So it's one of the most acidic substances that we know of, with actually stomach acid being a 1. So stomach acid or hydrochloric acid can corrode pretty much any substance that we come in contact with. A substance of a pH of 14 would be liquid drain cleaner. It's on the other end of the scale, and just because it's basic doesn't mean it's not dangerous, because we all see what Drano does to substances in a clogged pipe. It pretty much just disintegrates it, just like an acid would if we put in contact with it. So we need to be careful when we're talking about acids and bases, because they can both be equally as dangerous in the long run. So the body maintains homeostasis with a pH of 7.35 to 7.45. You would think that the body would want to be in a neutral state with 7.0, but our body functions ideally at just a slightly alkaline state. So right here, just a little bit alkaline, not too much though. It's not an 8, but it's also not a 7 or a 6. So if our body ranges get out of whack, so you see at 6.8, which is barely any movement at all on the spectrum, we start getting sick and we start experiencing symptoms of acidosis. And then when we get down here to 3.5, we can't survive anymore. So if our body between 6.8 and 3.5, which is only a 3-point margin, we can get extremely sick. We need extreme interventions, and we need to get patients to the hospital, but there's no way to check a pH on a patient on scene. We have to use the symptoms and the patient's history and the complaint to kind of justify if we think acidosis or even alkalosis is present in our patient. And we'll go over that here in a little bit when we get down to patient symptoms and complaints. So homeostasis does get interrupted. We're unable to maintain that all good balance of our bodies. And the deeper it gets on this spectrum, which was right here, the harder it is for our bodies to naturally combat acidosis or alkalosis. And also the harder it is for our bodies to recover if we can fix our patients either on scene or at the hospital. So we're either acidotic, which is a low pH, less than 7, or alkalotic, which is a high pH, which is greater than 7.45. So we got to kind of figure out what we're dealing with, and like I said, there's no way to check a pH on scene. We don't do arterial blood gases. That's just not a skill in the paramedic scope of practice. But again, we can take complaints, symptoms, and medical history to make an assumption and kind of guess if they're going down that acidotic or alkalotic route. So imbalances can be placed into 4 different categories, and when we're talking about the different categories, there's different body processes involved with each one. So we have metabolic acidosis, we have metabolic alkalosis, respiratory acidosis, and respiratory alkalosis. Acidosis is a more common imbalance than alkalosis is. We see a lot of acidotic patients due to major chronic illnesses or acute traumas than we do alkalotic patients. We don't run across that very often, but when we do run across these patients with alkalosis or imbalances, we need to recognize it and we need to know what we can do to try to relieve those symptoms or fix and reverse that alkalotic process. So with metabolic acidosis, it's pretty easy. Any type of metabolic process that causes acid levels to build up in the body. So if we think about our metabolic processes, some of them would be diabetes, or some of them would be the renal system. Lactic acid buildup secondary to anaerobic respiration. And anaerobic respiration is respiration without gas exchange. So something like hyperventilation or working out really hard, where our muscle tissue tends to break down and release lactic acid due to hyperperfusion of tissues and organs. So shock would be another one that releases lactic acid, and then cardiac arrest. When we're not perfusing our muscles appropriately and we're not getting blood to those end organs, they tend to break down, and lactic acid is the release or the byproduct of the muscle and tissue breakdown. So lactic acid is probably one of the main forms of acidosis that we see, and lactic acid is actually a pretty strong acid. So ketoacidosis we see in diabetics, especially hyperglycemic patients. So cells are forced to switch to begin metabolizing fatty acids for energy because they're unable to use glucose due to insulin deficiency. The byproduct of fat metabolism are ketones, which are extremely acidic. So when we have a patient who we assume is in ketoacidosis, we see them with a blood sugar of greater than 400 usually, and we see them with those Kussmaul respirations. They have the fruity flavor on their breath. We could assume that they're in ketoacidosis, and that could be potentially life-threatening for the patient, and we need to figure out, we can't really reverse it in the field, but we need to get them to the hospital and let them start working on them. And then, simple things like GI problems, diarrhea, the stomach bug, removes bases from the body, leaving just acidic substances behind and nothing to neutralize them. So one of the things that neutralizes acid is water, and if we're dehydrated, we're unable to do that. So the body's natural way of compensating for metabolic acidosis is tachypnea, or rapid breathing, hyperventilation. We do this because we know that when we blow off carbon dioxide, and carbon dioxide is acidic, that we expel some of the acid from the body. And it's kind of a secondary process. It's a natural process that our body does. And if we can do that and lower acid levels, we can try to get back to maintaining homeostasis. And we'll go back to ketoacidosis, and we'll even go back to lactic acid buildup. So with a diabetic ketoacidosis patient, you see those Kussmaul respirations, the fast, deep breathing, and that's because the body is trying to blow off that excess acid. And lactic acid buildup we see a lot in septic patients. We know that septic patients and lactates kind of correlate together, so they have lactic acid buildup as well. And we see a lot of septic patients hyperventilating or tachypnic, because that's the body's natural defense mechanism to blow off as much of this acid as we possibly can. So some signs and symptoms of metabolic acidosis: we have vasodilation, and we see that in septic shock a lot. CNS depression or altered mental status. So when the acid gets to be too high, we tend to get confused, unable to follow directions, kind of lethargic or sluggish. We have headaches, have hot, flushed skin. So think of carbon monoxide poisoning and how we're unable to expel that because it has a stronger affinity to the red blood cells than oxygen does. And a sign and symptom of carbon monoxide poisoning is hot, flushed skin. We have hypercalcemia, elevated calcium levels in the blood, tachypnea, nausea and vomiting, and then the end game is a cardiac dysrhythmia. If our bodies can't maintain this state of acidosis and it progresses to be life-threatening, we're going to see lots of cardiac dysrhythmias, anything from VFib, VTAC to sinus tachycardia, and we need to learn how to treat them in the field. So treatments, sodium bicarb is the main go-to medication we use to treat acidosis in the field. It's the same thing that we put in the swimming pools. It's the same thing that we keep in our refrigerators. It's a basic substance, and it neutralizes the acidosis. So if you think about a cardiac arrest with extended downtime, like what we talked about a minute ago, we have extended downtime in cardiac arrest. One, we're not breathing, so we're retaining carbon dioxide. That's acidic. Two, we're not perfusing our end organs, and they start to break down just like the anaerobic respiration, and lactic acid is the byproduct of that. So when we give sodium bicarbonate, that is the neutralization to that acidic state. We can also think of crush injuries. So if someone's been pinned in a car for a while, or if somebody has been in a machinery accident and they have a crush injury to their leg, one of the things we do in the field is we give bicarb to neutralize the lactic acid buildup, because once we release whatever is crushing the patient, all that lactic acid from muscle breakdown and tissue breakdown is going to release back into the bloodstream, and they might not be in an acidotic state before we remove the crush injury, but once we remove whatever is crushing them, our bodies can acutely go into an acidotic state. And we see a lot more deaths, not with the crush injury itself, but with the acidosis that's secondary to releasing whatever is causing pressure and causing the lactic acid buildup. So depending on your agency and what the protocols are, some people might give an amp of bicarb, they might give 2 amps of bicarb, it might be time related, but we want to get that bicarb into these patients pretty quickly, and we want to have it able to neutralize these acids, so when we do relieve what's crushing them, we're not going to kill them per se from the rapid acid buildup. So we get down to cardiac dysrhythmias and metabolic acidosis. We need to be on top of our game and have these patients on the monitor, and we need to figure out what rhythm they're in, and we need to do it fairly quickly. So we can use lidocaine, we can use magnesium, cardioversion, defibrillation, depending on what rhythm they're in. And depending on your agency, you might also have amiodarone on board. We just want to be able to recognize that crush injuries, cardiac arrest, and acidosis are all going to cause cardiac dysrhythmias in the long run, and we have to be able to treat them appropriately. So metabolic alkalosis. This occurs kind of the opposite of acidosis, when there's an excessive loss of acid from increased urine output or from decreased acid levels in the stomach. So it's rarely seen as an acute condition, but it's common with chronically ill patients and patients going under NG suctioning. So if we have an NG tube or even an OG tube in these patients, and we're constantly sucking their stomach out or suctioning their stomach out, we're taking all that acidic substance out of the body. So there is no more acid in the body, and we become alkalotic. So vomiting from illness or eating disorder, so anorexia, bulimia, mainly bulimia, we tend to lose that stomach acid when we regurgitate. Drinking large amounts of water, so people who exercise a lot or who tend to just chug water on a hot day when they're outside doing yard work or things like that, it dilutes the stomach acid. So if we dilute that stomach acid and we no longer have a pH of 1 in our stomach, but now our pH is 4 or 5, we're unable to neutralize the basic substances and we become alkalotic. Excessive intake of alkaline substances, one of the best examples of that is a patient who's been complaining of chest pain for a few hours or a few days. They think it's indigestion. They think they might have GERD or acid reflux. And instead of calling 911, they try to treat themselves at home. And what they do is they take way too many antacids or Tums. So they think that the Tums are going to help with the indigestion, but at the end of the day, it's not indigestion, it's cardiac-related chest pain. But they don't know that. So if they take too many of these Tums, say they're popping 2 or 3 of them every 2 hours, excuse me, they tend to neutralize the acids and we become in an alkalytic state. Now that's not necessarily life-threatening, but it's a good thing to know and a good thing to report to the physician when you get to these patients at the ER and say, hey, they've been taking, they took a bottle of Tums over the last 36 hours, they had no relief for it. And when they do blood gases on these patients, they're probably going to see that their pH is 9, 10, or 11, and they're in an alkalotic state. Good thing is that the Tums wear off fairly quickly, and the body can get back to a homeostatic environment fairly easily. So signs and symptoms of metabolic alkalosis: confusion or altered mental status, muscle tremors and cramps, bradypnea or hypoventilation. They breathe at a lower rate because they're trying to retain the carbon dioxide, versus acidosis breathes at a faster rate to expel the carbon dioxide, and hypotension. So when we talk about treating an alkalotic patient, especially metabolic alkalosis, The body's natural response to alkalosis is the most common treatment. It'll induce bradypnea or hypoventilation, what we just said, which will cause CO2 retention. And CO2 retention, if we can retain some of that acid, it might, over a period of time, regain a neutral or a 7.35 to 7.45 state, and homeostasis can resume. For hypotensive patients and alkalotic patients, we need to be careful not to overload them with a fluid bolus, because for the very same reason a minute ago, with excess fluid intake neutralizes the acid. So if we load these patients down with 1 liter or 2 liters of fluid and they're already alkalytic, we've made the alkalosis even worse. So if we can recognize metabolic alkalosis in the field, a pressor such as dopamine or Levophed or push dose epi or whatever your system uses might be a better solution to the problem if they're symptomatic and need blood pressure resuscitation. So instead of giving fluids, we could use one of these and maybe have a better result and not overload these patients with fluid and neutralize any more acid than we're going to. So respiratory acidosis, this kind of entails a whole lot of things, and in my opinion, I think we see a lot more respiratory acidosis in the field than we see of any other kind of process dealing with acid-base balance. And we're going to get into these and kind of discuss a few of them and how it relates to acidosis. So it's always related to hypoventilation or inadequate oxygenation. So if we're not breathing appropriately, if we're not breathing fast enough, or our tidal volume is insufficient, then we're not going to expel as much carbon dioxide as we feel that we should. And in turn, our body becomes in an acidic state. So increased carbon dioxide buildup, which is unable to be expelled via a regular inspiratory and expiratory pattern. We know that with respiration, we have to have adequate tidal volume and minute volume in order to oxygenate our bodies appropriately. So, and if you think about that, and then we get down here to these causes, it's going to make perfect sense at the end of the day. So some things that will cause an air or respiratory acidosis is one, an airway obstruction. If we can't bring air in and we can't have a normal gas exchange at the alveolar level, then we're going to retain carbon dioxide. So, and that makes perfect sense that an airway obstruction is going to cause respiratory acidosis. Obviously, cardiac arrest, we've already hit on that. If we're not breathing, we're not expelling CO2. Opiate overdose. So one of the main signs and symptoms of opiate overdose is hypoventilation. We have patients who take too many opiates, whether it's purposeful or by accident, and their respiratory drive slows down. So if they're only breathing 2 or 3 times a minute, they're not able to expel that CO2 that needs to be expelled, and they go into an acidotic state. A near drowning, our lungs get full of fluid, same thing. Respiratory arrest, kind of the same deal as cardiac arrest. Pulmonary edema is a really, really good one. So with pulmonary edema, it's similar to near drowning. We have all that fluid build up in the lungs. We hear the crackles and the rails, and when that happens, the oxygen, the gas exchange isn't able to take place. We're almost internally drowning ourselves. So if we can't exhale properly and the gas exchange can't take place because there's too much fluid in the lungs, we're going to build up carbon dioxide that way as well. A closed head injury, think of Cushing's triad with the irregular respirations that are either super deep, super fast, Cheyne-Stokes respirations. We're not going to get adequate gas exchange that way. Another good one is chest trauma. So if we have a hemothorax or a pneumothorax, what do you think is going to happen when we have to exchange oxygen in the lungs, but one of our lungs is deflated? We can't do that adequately. And a hemothorax in this instant would be a little more severe than a pneumothorax. A pneumo we can fix, we can decompress the lung, we can get gas exchange back to the way it's supposed to be, and we can get these patients back to a homeostasis kind of environment while we're getting them to the hospital. Carbon monoxide poisoning. we know carbon monoxide has a higher affinity to hemoglobin than oxygen does. So if we have patients with CO poisoning and their pulse ox might read 100%, they might have clear lung sounds, but at the end of the day, they have the hot, red, flushed skin, little bit of altered mental status. The fire department goes in and they see that the CO levels are through the roof. Well, these patients are going into an acidotic state because they have gas exchange, it's just the wrong gas. The carbon monoxide, when it binds to the hemoglobin, kind of kicks the oxygen molecules off the hemoglobin. And when we do that, we can't exhale carbon dioxide because there is no oxygen exchange taking place. And COPD patients are a good one. They live in a pretty acidotic state. Not extremely acidotic, but these patients live in a slightly acidotic state, and we hear of hypoxic drive all the time. We hear of free radicals and not wanting to over-oxygenate these patients. And that's because these patients live in a state of chronic bronchoconstriction. So the bronchioles are constricted, they're smaller. It's kind of like comparing a fire hose to a garden hose. And when we have garden hoses in our lungs instead of fire hoses, we're not able to off-gas like we should. So we have to really watch these patients. And one of the things we're going to talk about in a little bit is end-tidal CO2 and monitor these COPD patients and just kind of see where they're sitting. But when they get into an acute COPD exacerbation or an asthma attack, I mean, you can even think of an anaphylactic reaction in the same category as these COPD patients because it's all reactive airway disease. But when we have this acute bronchoconstriction and patients can't breathe, they tend to build up acid fairly quickly, even though we see a lot of them hyperventilating. The hyperventilation isn't enough to kick off all these CO2 molecules compared to what they're retaining. So we have to look at that as an acute cause of respiratory acidosis. So signs and symptoms, treatments, we've talked on a few of them. We're going to hit these. Signs and symptoms, systemic or cerebral vasodilation, and that gets down more to the shock level, to after the body's compensatory mechanisms start to fail. We get headaches, red flushed skin, again, CO poisoning, CNS depression, altered mental status, bradypnea, nausea, vomiting, and hypercalcemia. So some of the treatments we use to manage respiratory acidosis, high flow oxygen and aggressive airway management is the most beneficial treatment. And even with these COPD patients who rely on their hypoxic drive, we are not going to hurt them any more than they're already hurt in the short period of time we have them by giving them high flow oxygen. We need to expel as much carbon dioxide as we can off of these people, and oxygen and proper airway management is the best way to do that. Another one, the body's natural reaction to respiratory acidosis is the renal buffer system. But it works really slowly. If we think how many times we urinate every day, it's really not that many. And when we urinate, we release acid, but it works too slowly to combat rapidly progressing respiratory acidosis. So we would have to constantly produce urine and produce enough of it through the kidneys in order to make this beneficial. So we just need to know that it works. It's a slow working process, and we need to do other things in order to get this body back to a homeostasis type of environment. And again, airway management is key with this, whether it is high flow oxygen or it's intubation, ventilation, whatever we need to do to blow off as much of the CO2 as we possibly can. So, and here's what it says. We can use end-tidal CO2 detectors to measure the amount of carbon dioxide present. So end-tidal CO2 detector, we have two different forms of them. We have nasal capnography for our conscious patients, and then we have an end-tidal CO2 detector that will fit on top of a King Airway or an iGel or an ET tube. So when we ventilate these patients, we can actually get real-time numbers on what their end-tidal CO2 is. A normal end-tidal is between 35 and 45 millimeters of mercury. So one of the things, end-tidal CO2 for a nasal cannula, we have a nasal cannula. This doesn't have an end-tidal device on it, But what the end tidal device is a little prong that sticks on the other side of the nasal prongs, and that measures the amount of carbon dioxide being exhaled. And it's the same thing with our end tidals for our ET tubes. So when we're ventilating our patients and we have this bag valve mask hooked up, one thing we can do is we can take this mask off, and there's almost the same thing. It's a little plug that plugs in, and then it's an adapter. We can plug the BVM mask right back to it. And both of these things plug into our cardiac monitor. So it gives us a real-time reading of the exhaled carbon dioxide, and it lets us know how much carbon dioxide is being retained or how much carbon dioxide is being released. And it's a great tool to have. It's great to work with, but at the same time, we need to train ourselves to understand what waveforms look like, and that's a whole nother lecture about CO waveforms. So increased end tidal CO2, so something above 45, indicates hypoventilation and acidosis, increased CO2 buildup. A solution would be to assist ventilation or ventilate a little faster to blow off some of that CO2. And we'll see if it comes back to a normal reading. A decreased is the exact opposite, and we can adjust, we can slow our ventilations down and build it back up. So ventilation is really important when it comes to maintaining end tidal and CO2 release. There is a couple caveats to that though. So when we're doing our cardiac arrest, when we're working a code, we tend to ventilate as fast as we can. And studies have shown now that we only want to ventilate between 6 and 10 breaths a minute. So when we're doing 200 compressions a minute, we only want to ventilate like every 20 compressions, or maybe even a little bit less, and we want to keep it in between this 35 and 45. When we ventilate too fast, we're going to see a decrease in end tidal. When we ventilate too slow, we're going to see an increase because of the CO buildup. But one thing we got to look out for is that if we're running a cardiac arrest and their end tidal is less than 35, say it's in the 20s, 25, 27, 29, but then all of a sudden it jumps to 45, 50, 60, that might not be because we're ventilating inappropriately. That might in turn indicate a return to spontaneous circulation. So if we see that, we need to recognize it. We need to do rhythm checks at the end of our CPR cycle and see if we actually do have return to spontaneous circulation. And the last one is respiratory alkalosis, and we rarely see this. Sometimes we notice it in the field, but I think the acidosis, in my personal experience, is far more common, caused by hyperventilation instead of hypo. So we're breathing too fast and we're blowing off all this CO2, and it's mainly due to an event such as an anxiety attack. We see patients who have anxiety or nervous breakdowns, and they start breathing so fast that they have carpal pedal spasms, tingling in their fingers, or they get all crunched up like that. We see them with tingling in their lips and their face. But there's also underlying conditions that could cause hyperventilation. Pulmonary embolism is one. We see them really, really anxious because they can't breathe, so they're breathing faster. Acute MI, a septic patient, a ketoacidotic patient, we hit on that a little while ago. And other causes are drug overdoses, specifically an aspirin overdose, fever, and what we just said a minute ago, excessive BVM ventilation. So when we ventilate our patients too fast, we put them in a state of respiratory alkalosis. The good thing is, it's easy to fix excessive BVM ventilations. It's easy to fix the respiratory alkalosis if we induce it, because all we got to do is slow down our ventilations and it'll go back to normal. So signs and symptoms of respiratory alkalosis: decreased LOC, lightheadedness, the carpal pedal spasms that I just talked about, tingling lips and face, chest tightness, confusion, we can put that up with decreased LOC, a little bit of vertigo, blurred vision, hypocalcemia, this is the first time we saw that one, and nausea and vomiting. So when we treat these patients, the most important thing is to find the underlying cause of hyperventilation. If it's because of an anxiety attack, we can coach these patients down to a normal respiratory pattern. We don't want to do the paper bag method. We don't want to do any of that. But if we can coach these patients down and get them to slow their respiratory rate down, these carpal pedal spasms and the tingling of the lips and the face, they'll resolve. So we kind of fix that for them, but it's up to them to really slow the respiratory rate down. If we're overventilating our patients, slow down our BVM ventilations. It's up to the crew chief on the scene to monitor the end-tidal CO2 and kind of watch how fast they're ventilating these patients. So it's different to distinguish all this in the field. We can't take a pH on our patients. We can't get a blood gas on the field. It's just not possible for us to do. It's not in our scope of practice. But we can do a proper assessment, and we can look at signs and symptoms and patient history to kind of determine if they're in an acidotic or an alkalotic state. We can do that on our own, and it might not be something we can fix, but it can be something we can relay back to the ER. And if we can fix it, we need to recognize what it is. And a lot of these are dealing with airway issues again, or respiratory issues that we might not fix completely, but we can start to reverse the respiratory acidosis in the field and get these patients back to a state of homeostasis. It's extremely important to assess our patients. Is it traumatic? Is it medical? Is it both? And do we have a patient with a closed head injury and a pneumothorax? Or do we have somebody who is having a COPD exacerbation and wrecked their car and now has chest trauma from hitting the steering wheel? It's extremely important to assess our patients, find what we can fix it quickly and fix it appropriately, and get these patients to the ER to where they have continued care. So, just like managing a swimming pool, we need to manage our patients to ensure that homeostasis is not interrupted. If it is interrupted, we need to figure out how to fix these patients and how to adjust what they're doing or what we're doing to get back to a homeostatic environment. We have interventions that we can perform. We can give vaso or bronchodilators to our reactive airway disease patients. We can ventilate our unconscious patients with airway compromise. We can try to push fluid out of the lungs with our pulmonary edema patients with CPAP. We can combat ketoacidosis by ventilating those patients if we need to. There's a lot of different things we can do. We can give sodium bicarb. And while we're on sodium bicarb, we'll hit on that a little bit. So sodium bicarb normally comes in a 50 cc vial, just like this. This isn't bicarb, but for all intents and purposes, we're going to say it is because the vial is almost exactly the same, except it has a yellow top and it says bicarb on it. So when we give sodium bicarb, most agencies are either doing 1 vial for an adult or 1 milliequivalent per kilo. So bicarb comes packaged 44 milliequivalents per 50 cc's. Now, when we have an acidotic patient or we're in the state where we're going to give bicarb, we're nervous, our adrenaline is pumping. You know, it's not a medicine we give normally except for critical patients. So it's a big vial with a small little spout. So when we give this, we want to give it slow and steady. We don't want to slam it, because if we do and we're forcing 50 cc's through that little exit port, we're going to blow a vein, and then our bicarb is useless. So we want to be able to give bicarb, and we want to do it adequately. So let's not slam it in. Let's take our time, and preferably through we don't want to push it through a 22. I'd like to see, you know, a 20 gauge, 18 gauge, preferably, or even a 16 gauge to make it easier to administer that medication. But that's the main medicine we use. And when we take steps to ensure our patient is treated appropriately, they'll more likely have a favorable outcome. Everything will be all good. We do these interventions for our patients. We recognize that our patients are sick. We recognize what type of illness they're experiencing, and maybe we don't know. Maybe we don't know why they're in the state they're in. And we don't have to know why all the time, but we have to recognize symptoms. We have to recognize that opiate overdose has bradypnea, hypoventilation, and while they're only breathing 2 times a minute, they're going to have carbon dioxide buildup. Do we have to give bicarb to these overdose patients? Probably not. We're going to try Narcan. We're going to try BVM ventilations first. But if it progresses and our treatment it doesn't show improvements, we might have to give bicarb at some point. It's not in the protocol for an overdose, but it is for cardiac arrest. And we might need to call for orders if we're ventilating this patient for 20, 30 minutes with no improvements. But we just need to recognize that something like that does cause CO buildup. We need to recognize that our anxiety attack patient, although we don't know what caused the anxiety, is going to cause excessive CO2 blow off. So we need to understand that the way to get them back to a homeostatic state is to get them to slow their breathing down, to return to a normal respiratory pattern where they have adequate tidal volume and minute volume. Breathing 60, 70 times a minute isn't healthy, and eventually they're going to pass out. One of the other things that I'm going to say is all these signs and symptoms are very similar. So we can't just go off of signs and symptoms alone. And that's just where we're going to end right now. We're going to end by saying that just because they have signs and symptoms doesn't mean they're acidotic or alkalotic, because we can't really base all that off there. It's based off of a proper patient assessment. It's based off of knowing our protocols and how to treat our patients. And it's based off of just overall good patient care. So if we can recognize what's going on, we can treat our patients appropriately, we can apply the correct interventions, then we can manage our patient, we can be more confident in our patient care, we know what tools we have in our toolbox, and we can use them to benefit our patient. Thank you very much.